delivered numerous presentations and workshops at agencies and at regional conferences, such as NYSAPRA and the YAI International Conference. His work includes supporting and representing organizations in industry-wide meetings and work groups in New York State. Mr. Thompson works as a consultant to agencies to develop new programs, provide trainings, and to research grants and policy. He holds an MPA degree in healthcare policy from Baruch College and is a subject matter expert in healthcare policy, care coordination, and managed care, and for people with intellectual and developmental disabilities. He is passionate about MSC services. He said he's with his people now. Having spent several years as a director of MSC programs, for this reason, given the developing changes, Mr. Thompson has dedicated much of his time training and developing MSC staff to prepare them for the future. Please join me in welcoming Andre Thompson.
Wow, good morning. Good morning. How do you live up to all of that? Thank you very much, Janine. Like she said, I'm very much with my people. Very, very, very happy to see all of you here today. At all places, the Presidential Library for FDR. This MSC consortium is really doing it up, right? I've been to a few conferences, but not at the Presidential Library. I made a mention that I was going to be presenting today at here, and someone on my LinkedIn page asked me, is it going to be archived? I'm like, listen, these are the things that they actually reserve for presidents, you know. But anyway, I'm very, very happy to be here with you. Thank you for spending your morning here with me today. You get some time out of the office, but today, this is not a billable activity, okay? So you won't be able to put it in the monthly note, right? So very, very happy to be here and spending time with you. Over the past few years now, as you know, many of you have probably been in the field for a long while. I have. Right? No show of hands, it's okay. We don't need to age ourselves, date ourselves. But I feel like over the past 3, 4, 5 years, just the amount of changes that we're seeing, right? These are very challenging times. These are very difficult times. Changes at the DDRO, new people. I was here in the field during the whole front door rollout, that whole debacle. Huge, come on, don't pick on the front door. It's been what, 3 years? Janine, what, 3? Yeah, come on. So there's just been a lot of changes in the field. And I've grown up in the DD field, straight out of college. And I've been, you go back to school, you educate yourself, but I happen to be in places and sitting at the table while we were discussing some of these changes, how we're going to confront some of these changes, and what we need to do to prepare. And somewhere along the line, because the heads of the agencies, the bigwigs, they get together and they talk and they decide how the agency and even at the policy level, there's a discussion about what's going to happen and how the field is going to move. But we weren't really spending much time preparing, the line staff, the MSCs, the MSC supervisors, the day hab folks. And so over the past 3, 4 years, I've just basically taken it upon myself, because I've grown up in the field. I've been in MSC for years. I'm not going to be writing a case note today on this, but I've taken it upon myself to spend some time coming to conferences like these, visiting various agencies, basically wherever folks will have me, doing some of this, briefing the MSCs on the changes that are coming, and what we need to do to prepare. So the big talk is, among all of these changes, is care coordination, right? And I've been to a number of these forums, conferences, and the MSCs are worried. What's going to happen? Well, don't worry. We're moving forward with MSC. And I'll get to it later in the presentation, but MSC is not going anywhere. From my perspective, this is the world according to Andre. But before MSC, there was something else. CMCM. Don't date yourself. Okay? So it might look different, somewhat different, going forward, but MSC is a very important service. I can't stress it enough. And I'm also preaching to the choir, right? Go ahead and pat yourselves on the back. MSC, in the world according to Andre, is the most important service in the OPWDD system. I may be a little biased. And we'll go through those in a little while. So MSC isn't going anywhere. All right? Now, we're seeing all of these changes for many, many, many reasons, but they really boil down to a few. Right? So pick your favorite change. All right? This talk about care coordination. This talk about value-based payment. Right? Am I throwing around stuff that folks are not familiar with yet? Value-based payment, delivery system reform incentive district program, Medicaid managed care, Medicaid redesign, you choose it, right? The alphabet soup of these changes that are going on. But they are happening for 1, 2, or 3 reasons, namely costs, improving outcomes, and improving quality. Does that make sense? So, what does all of that have to do with us? All of these changes just basically get us to refocus, realign, see where we're going and what we're doing, see the role basically that we play in the system. And before these changes can really come out, before we can really get moving with these changes, we have to reform the whole service delivery system. We have to reform how we get paid for services currently. Okay, all right. How many of you sincerely would pay $252.98 a car note for the service that you provide in a month to the individual that you support? Would you pay $252.98 for the service that you provide in any given month? You may or you may not, right? But we have to reform, and I'm not saying there's anything necessarily wrong with that, right? But the system that we're in now is a fee for service system. Does that make sense? Mm-hmm. A fee for a service. Mm-hmm. You're not getting paid based on the value of that service, based on the outcome of that service, whether or not quality has improved, whether or not you're actually reducing costs. You're not. It's how many days of day have, how many days the individual was at home. That's basically what it is. So we have to change the payment system as well, whereby the providers get incentivized to provide better service, get paid basically to provide better service. Care coordination is essential in this delivery system change and going forward. Absolutely essential. And finally, we have to be able to measure performance. We have to be able to measure our outcomes. So that's covering the waterfront. Now what's the moral of the story? And I'll get to the main points in a little while. we're in the healthcare business. Does that make sense? We're in the healthcare business. It is very, 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 very expensive. And we have to find ways, and we have to be surgical about how we go about things, in that we have to keep people healthy in their home, out of institutions, right? We have to pay close attention to care coordination. We have to develop measures for quality. And we have to, develop a population health management model. Now, what do I mean by that? There's nothing really prioritized or organized about what we do currently today. I know we do a world of good, but it's not very prioritized or organized in the way that it should, according to how care coordination should happen. So these are the key points. MSC is the most important service in the OPWDD system. The world according to one man, Andre. But we are in the healthcare business, and it is very, very expensive. Care coordination is required to achieve, we talk about valued outcomes all the time. Care coordination is required to achieve all of the valuable outcomes, such as lower costs, better quality, and more people being satisfied with their service. And service coordinators, this is why MSC isn't going anywhere, the world according to Andre. Service coordinators are needed in order to bridge the gap for families and individuals that we support, in order for them to play a better part in their own healthcare, which they are unable to do in many cases on their own. Does that make sense? Mm-hmm. Now, I guess I'm preaching to the choir. But MSCs wear many different hats. I've done it. There are things that we do that is absolute. One of these days we're going to get locked up. It's not written in the vendor's manual. There's no protocol for doing it. But we do it anyway because there's no one else to do it, and it's the right thing to do.
That's right.
Plain and simple. If you're super... No, we're not going to get anybody in trouble. But it's Friday evening, and Anthony's mother gets taken by ambulance to the local emergency room, the hospital, right? Chaotic scene. Anthony, there's no other family members. Anthony gets taken as well. There's one problem. While she's been seen, who is giving oversight to Anthony? Nobody. That security guard, you've seen him, he's very, aggressive. And that's to the professional folks and the doctors. What do you think he would do to Anthony when Anthony is doing his regular thing, and not sitting down? So it's Friday evening, 6 o'clock. You're heading out of town with your husband, your wife, boyfriend or girlfriend, and you decide to stay back with Anthony because there's no one else to do it. He has no other family, and it's the right thing to do. Yep. Some of these are personal stories, but I won't tell you which ones, so I don't get in trouble. Or Scott, he lives with his uncle. They love each other to death. No other family involvement. But one day, Scott's uncle just drops dead. It's heartbreaking for Scott. You know the relationship that they have very much. This is a time of crisis for Scott. Your agency, they provide MSC, but they also provide residential and that sort of thing. They also have a residential program. There's one opening. And what do? You try to talk to your director. You talk to whoever you can talk to get Scott in there. It's the right thing to do. It's an ICF though. And that's the one opening. Scott is mild, moderate. It's really not the place for him. But It's the right thing to do. And there are countless, you could share your own stories where this is concerned. There's countless other stories like this. You know one time what I did? A mother, she was more or less just decompensating, right? And she has a daughter. We actually provide MSC to the daughter, not the mother, but the mother had to go to the psych ward. And she has a lot of cats. Can you imagine? My supervisor, he was an enabler. Beautiful human being of a guy. Having the keys for the days, for the week, she was in the hospital, going to this lady's house and feeding her cats.
Wow.
Who does that?
MSC.
So, we do a lot of stuff that, one of these days it's going to get us locked up. It's not written down anywhere. It's not in the vendor's manual. But we do it anyway because there's no one else to do it. And it's the right thing to do. So we wear many different hats. Counselor, advisor, therapist, advocate, friend. You name it, right? I'm preaching to the choir, right? MSCs?
Yes.
Now, so that's one model of it. And we're worried about moving to care coordination for MSCs, but do we do care coordination now? We do? So why are we worried? We do, right? According to OPWDD, this came from some of their literature, we do care coordination. And it's been a part of our model for years, right? The ICF and the ITT process, right? PCSS is one model. And what's the other one?
MSC.
MSC. So we do a lot of things because it's the right thing to do. There's no one else to do it. And we do it with heart. But there's also a science involved. That's the part that we have to get to that point. We have to figure that out, right? What's measurable, what's quantifiable, what's evidence-based, what's keeping people safe, what's reducing ER visits, what's, so that thing that I did for Scott, no, that isn't the thing to do. That is it was the right thing to do, but that's a more restrictive setting. And as you can see now, we're moving away from that. So we do it with heart, and we do it because it's the right thing to do, but we may not be doing it right. It's the right thing to do, but we may not be doing it right if it's not reducing costs, improving outcomes, if it's not measurable, if it's not evidence-based, all of that. So, let me ask this terrible question. How do you decide on any given day when you get to the office? You're here today, but when you get to the office, how do you prioritize your service coordination activities? See, we have individual cases, but we serve a caseload of people. And MSC is targeted case management, right? But how targeted is it? Targeted to the right person at the right time? How do you decide on any given day what gets your attention?
I usually think about the people that are out in the community where there are natural supports.
We think, very good. Think about the people that need the supports. I have a very simple method. But it's backed up by research, the world according to Andre. A simple, random sample. Right? You remember when you do your research papers, right?
Yeah.
You. Or eeny, meeny, miny, mo. No, I'm kidding, right? But how do you prioritize on a daily basis what gets your attention?
Yeah.
That's how you'd like to do it.
That's the question.
But the truth is, it's a squeaky wheel that gets the grease.
Yeah.
So you're here today, right? Tomorrow, when you go to work, that message light on your phone is going to be flashing. It's going to be lit.
Monday.
Beep, 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 beep. You have 21 messages. First incoming message. Mrs. Torres. Beep, 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 beep. Second incoming message. Carmen Torres. Third incoming message. Carmen Torres. Fourth incoming message. Andre, when you come in, I'd like to talk to you about the SNAP recertification from Miss Rosenberg. That's your director. Beep, 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 beep. Fourth incoming message. Carmen Torres. You get the point. It's a squeaky wheel that gets the grease. And you know, what is she calling for? She's calling about the day program. Again. And you know, right? It's not the day program, it's her. Right? Because this is the 5th program, and you have to pull strings to get her in there, to get, you know? But what do? It's a squeaky wheel that gets the grease. And you go and you speak to your director who calls you into the office to reprimand you because you didn't do the SNAP recertification for Miss Rosenberg and her son Max. Hold on a second. Truth be told, Miss Rosenberg is actually pretty wealthy, retired, but wealthy. Max has a little job. And you know how much Max gets for SNAP?
$16.
$15. 15. Meanwhile, and this is what you're chasing on a daily basis. Meanwhile, someone has eloped from the group home. Brad has been arrested. Anytime you hear me say in this talk, again, you know it's not the first time. Brad has been arrested. Again. In Chinatown. For soliciting prostitution. And being charged with rape. This is what you're up against. And you could name the different crises that pop up on a daily basis. But how do you decide? Paper, rock, scissors? How do you decide? What gets your attention? The truth is, we do the very best we can with what we have.
Yep.
Right? And we do it with much heart. So that's the title, right? Heart or science. That kind of play on words. Art, you know, but that's what we do. So we have to figure out the art and the science of care coordination. Right now we do it with much heart. But all of this, it's not really our fault, right? It's sort of the system that we're in. So, how do you decide? This is the Eisenhower decision matrix. And you have issues that falls into urgent and important, important, not urgent, urgent, not important, not important, not urgent. I'll wait. Where does Mrs. Torres, what are you going to tell her? Where are you going to tell her that she fits? Where are you going to tell her that she fits? I'd like to see you try.
Yeah.
But it's not our fault, right? We lack the timely information. Something happens in the same agency, in the group home, right? And the MSC is the first to know. 2 months later. Something happens, and it's a crisis. And just at the moment that you need that service, is a service that they don't have. So what are you going to do? Get to the front door? You don't have enough time. He needs emergency respite right now. Or emergency housing, whatever it is. And so we don't have all of the information about the person sometimes and all of their services outside even of our field, other fields, right? Because some of our folks are in different parts. We don't have it. It's not coordinated across systems. And our cases always reserve the right, no matter how many times you've done it, to act on their own behalf. No matter how many times you've done it, again, after straightening out the Medicaid, they go and enroll in managed care. You gotta fix it. All right? That's what we're up against. But care coordination is an evidence-based, patient-centered. In our world, we say person-centered, but it's really the same thing. It's multidisciplinary. It's coordination across disciplines, roles, functions, institutions, you name it. And it's integrated. That's where we need to get to. And right now, the changes that we're seeing, in terms of going back, in terms of the moral of the story, is due to poor care coordination, deviation from evidence-based practice. You know, you may have sensed that I have a little accent, right? So I'm from the islands, I'm from Jamaica. And, you know, you go home on vacation, you know, with grandma, you have a stomach ache, and she wants to boil some bush. I won't tell you what kind of bush it is. Cersei. Yes. Whatever it is, she wants to boil something that will make it better. Now, growing up, yeah, you know, it may perhaps make you feel better. But it's not written down anywhere. It's not evidence-based. You know, so we deviate from evidence-based practices all the time. We fail to catch problems early. And we fail to address psychosocial issues. And that's why we're here. That's why we're here. And that's why we're so important. Those psychosocial issues, we're not doctors, right? And we're not nurses. But those psychosocial issues, anyway, we'll get to it a little more. That's what we do. That's our business. Every day. So we're in the healthcare business, and it's very, very expensive. The United States spends $2.7 trillion every year on healthcare. About $8,000 or $9,000 per person. And we have the worst outcomes in the world. How does that happen? Out of 11 countries in the world, the OECD countries, right? The industrialized nations, where do you think we rank out of 11? Number 1? Number 2? 20 out of 11? Oh, you're horrible. We're ranked last. And in the meantime, so we spend so much money on healthcare, and in the meantime, the outcomes are horrible. And let me just add, 40% of the outcomes are attributed to, well, you could attribute these poor outcomes, 40%, to that failure that I discussed of addressing the psychosocial issues. It's due to what you call the social determinants of health. I'm speaking your language now, I'm coming up your street. It's the housing that you're doing, the residential programs that you're doing, it's the employment, it's filling out that birth certificate application. It's all connected. 40%. So that's where we are, and that's what we're doing. Now, when we talk about healthcare, before I get to care coordination and why we're here, let's break down healthcare a little bit, right? In healthcare, it's the cost. The problem is the cost. I don't know what your politics is. I don't care. Right? Maybe you hate the Affordable Care Act, Obamacare. But something had to be done. And people like myself and others who take a serious look all the time at healthcare policy, you see the problem. We have the most fragmented, uncoordinated system in the world, without the outcomes, the better outcomes to show for it. So, when it comes to healthcare, we're talking about, in the broadest terms, the outcomes that we want is, we want it to be low cost, we want it to be good quality, and you want to be satisfied about it. When we talk about costs, there's a question of cost effectiveness. All right, there's a little economics here. Let me ask you this question. Because right now, it's fee for service. A fee for a service. We just swipe that Medicaid card. Everything, swipe that Medicaid card. A fee for a service. But if you have to consider the cost as to whether or not something is worth doing, whether a service, whether an intervention, whether it's you yourself, we don't think about it in these terms, receiving some medical treatment, is it worth doing? So let me ask you this question. There's a quick quiz. If you're going to do an intervention, an outcome, or whatever it is, and the cost goes up, and the outcomes go down, should you do it? No. If the cost goes up, and the outcomes go up, should you do it? Costs up? Maybe, right? Okay. The costs down, outcomes down. So you're spending less, but you're getting crappy outcomes. Should you do it?
No.
Don't look. If the cost goes down and the outcome goes up, now you should do it, right?
Of course
you should do it, right? Yes, you do. So that's the question here. That's cost effectiveness, right? So that's the first leg of the stool, the cost, and figuring out whether something is cost effective or not. The other part of it is the quality, and quality can be broken down in many different ways. But here's a quick piece from the Institute of Medicine on crossing the quality chasm. It's whether or not it's safe, whether or not it's effective, whether or not it's patient-centered, person-centered, whether or not it's timely, efficient, equitable. Ms. Rosenberg shouldn't get that knee-jerk reaction from you to move, because she called you a director, because she's a member of the board. It should be equitable. Oh, what did I do here? And finally, the third leg of the stool, you want it to be person-centered. And you could think of it in terms of yourself. You want to have that engagement from the people, from your doctor, from whoever is treating you, right? It's not enough as a clinician, as a nurse, a doctor, whomever you are, as an MSC, it's not enough to ask the person, what's the matter? But what matters? If that makes sense, right? You want the service that you're providing to be culturally and linguistically appropriate. So there's this barber that I used to go to. Doesn't speak any English, but he gave me a very good haircut. And you should see me in my Spanglish trying to explain trying to explain to my barber how I want the haircut. It's a very good thing my barber is not my MSC or my doctor, right? So those are the three legs of the stool when we're talking about the problems with healthcare and how to look at it. Now let's take a quick minute to define health before we get to what we're doing in care coordination. Does that make sense? This is the continuum of health. And I know it may seem like I'm spending a lot of time here talking about health and healthcare, but that's the business that we're in. I hope that's clear. We may not be doing medical services, but what we do is the social determinants of health, those social economic factors, 40%, right? That's what we do, 40%. And depending on who you ask, it's actually 90%. And 10% of the costs and the outcomes is actually medical, actual clinical care. It could be 90% where you live, who you live with, where you smoke, whether or not you smoke, whether or not you exercise. So this is the health continuum. You go from wellness to death, right? And basically, prevention is very, very, very important. An ounce of prevention, they say, is worth a pound of cure. And I don't care who you are, whether you're a doctor, whether you're an MSC, whatever it is. That's where you're starting, at prevention. You want to keep people healthy. You want to address those problems upstream rather than downstream when they're much, much worse, way more expensive. So before the disease sets in, the disease leads to impairment, right? Activity restriction, disability, and death, right? So that's the health continuum. And like I said, we're not just talking about healthcare, but the social determinants of health, right? Emotional, spiritual, physical, social, environmental.